Okay. All right. Well, welcome to the spring 2023 seminar series. It's good to see everybody in person and online. This semester we'll be doing like what we did last semester, where it's a joint hosted seminar series between Missoula City County Health Department and our public health program through our academic health department arrangement. We're very lucky to have Victor White come talk to us today. And Victor doesn't come to us from too far away. He's right across the river at Missoula College, where he's the director assistant professor of radiologic technology. And so we're also trying to work closer with Victor with our undergraduate bachelor's and master's and PhD programs in public health here within our school. And he has lots to offer, lots of great ideas, and we look forward to working with you, Victor, and fleshing those out, especially the new 2+2 with Missoula College coming into our undergraduate degree here. So a little bit about Victor. He started here in August of 2022, and most recently he was at Yellowstone Christian College as an exercise science instructor. He also has worked for Riverstone Health as a limited radiography. How do you say that? Radiography. Sorry about that.
It's a
program instructor.
X-ray.
And in City College, Montana State University in Billings as the program director for radiologic technology and ultrasound technology. So he has lots of different degrees and a very interesting background. His PhD was in health education from Southern Illinois University. He was the radiation safety officer, or took the radiation safety officer training at Harvard, and has a Master's of Arts in Environmental Studies from the University of Illinois, Master of Science in Radiologic Science from Midwestern State University, and Bachelor of Arts in Health Services Administration at the University of Illinois. So lots of different topics related to public health. And he's going to talk a little bit about his work at the Perce Reservation in Idaho, and take it away.
Okay, thank you. Well, thank you for that wonderful introduction. Welcome everyone, folks that are here in person and online. And so I kind of like to move around the room a little bit. So I may walk around a little bit. So hopefully that doesn't distract anybody. But what I want to talk about today is I have a personal research interest in osteoporosis. And when I worked at Lewis Clark State College and when I worked for the Nez Perce tribe in Lapwai, Idaho, Dr. Valerie Fox, who was Native American physician, a member of Ojibwe tribe from Minnesota, she found out that her grandma had osteoporosis, and she was 47 years old, and we tested her with the QUS ultrasound device, which is a decent screening tool. It's not the gold standard like the DEXA, but we found out that she had osteopenia. So she was very upset about that and was stunned at that. So she thought, I wonder how many other folks here, as far as clients and patients at the Nez Perce tribe, might need osteoporosis screening, counseling, and maybe we could find out what their knowledge is as far as do they know about osteoporosis? Do they know about proper diet and exercise to take care of preventable health problems? And so when I talked to Dr. Fox, I was getting ready to do my dissertation, and she says, hey, you already work here. I'm interested in this. My grandma, or my mom and my grandma had osteoporosis, and our mom had osteoporosis. She says, why don't you do your study here? And we already had a DEXA scanner because I helped them buy their equipment when they built their new clinic. So we had a DEXA scanner, which is the gold standard for testing for osteoporosis. We had a QUS scanner, which doesn't use ionizing radiation. So I thought this makes sense. There's a demand, a desire for this, and I have some degree of expertise. So that's how it got started. So take a look here. Let's look at osteoporosis. Everyone's heard probably the term osteoporosis. You may know someone that has that, or someone in your family, or maybe you have osteopenia or osteoporosis. But technically, osteoporosis would be considered a skeletal disorder. It's characterized by compromised bone strength, and there's a predisposition to an increased risk of fractures. And it doesn't take a lot of force on someone that does have osteoporosis. For example, an older person, say her grandchildren are visiting, she can actually pick up her grandchildren and cause a spinal fracture by doing that if she has osteoporosis or a hip fracture. We've screened patients that did have osteoporosis, and the owls they did was they walked out of their house to go get the mail, and they ended up having a hip fracture. So osteoporosis is sort of a hidden disease. It's the kind of thing that we don't always think about unless it affects some in our immediate family or friends. It's the kind of thing that a lot of government research dollars are not going to, because it's chronic and long-term. It is preventable through behavior change, exercise and diet, or medication, but also it's the kind of thing that it's not immediate the way heart disease is, or alcoholism, or it's not immediate the way increased risk of stroke or obesity is amongst Native American folks. So we take a look at the World Health Organization osteoporosis criteria, and there's a little more technical. Bone mineral density has to be 2.5 standard deviations below the mean bone mineral density for a healthy young white woman. And that's a T-score of negative 2.5, or fracture in the absence of significant trauma in postmenopausal women. Now, here's one thing that I noticed when I was doing my research. All of the databases that we use to detect osteoporosis in folks are based on young females and Caucasian. So the idea is that we don't have much data of different ethnicities or genders. Men get osteoporosis. Men are living long enough now to get that. Asian Americans, African Americans, other folks, Native Americans are predisposed to osteoporosis, possibly more than Caucasian women. So the other thing is the typical age of the person we use as our standard is 30 years of age, and basically weighs about 125 pounds, is 5'7". And so does that really mimic what we want to be comparing folks to in this day and age? So I talked to some reps at Merck in St. Louis, Missouri, and they said they would like to get some more data on Native Americans or other ethnicities and other genders. And so I did send my data to them when I was finished, but that was some time ago. So I don't know what happened to that. Now, this study was done in 2013. So this is an old study, but the idea is that my old professor, Dr. Deetnet Ratnagripa, he's the head of the MPH program at the medical school at Creighton University. He wants me to continue the study here in Montana. So it is a possibility that we would go ahead and do this kind of screening here in Montana. So the osteoporosis epidemic is going to worsen, aging population worldwide. The incidence, prevalence, severity of osteoporotic fractures should double by 2040, approximately, may quadruple by 2050. 1.7 million hip fractures in 1990. That's about 6.26 million by 2050. Those numbers fluctuate all the time, but it does show an increase in that. This chronic health problem is something that we need to actually address because it is preventable. So most research to date has been done on Caucasian women and men. Very little research has been done on Asian Americans, Hispanic folks, African Americans, or Native Americans. And so one of the reasons why I did this project was to try to gather some data regarding that on Native Americans. So epidemiology, of course, that's a study of disease in populations. So if we take a look at this, rates for osteoporosis vary among racial and ethnic groups. Data is best established for Caucasian females, as I'd already indicated. There's limited data available regarding osteoporosis fracture rates in American Indian and Alaska Natives. There's been some good studies done in Alaska and in Arizona amongst some of the tribes and physicians that work for the tribal health clinics. And some of that data I used for my research, but there's been a lot more studies amongst Indian health wanting to see if osteoporosis is a legitimate thing that affects more of the population than they realize. So we look at some risk factors here. I'm an X-ray guy, so I've got to do this. So anyway, so this is a cross-sectional axial image of the lumbar spine. It's actually a thoracic spine there because we've got some ribs coming in, but you probably can see some of the pathology already. So we've got the spinal cord right here. This is the main vertebral body. We got the spinous process and the transverse process, and we've got two ribs articulating with that costovertebral joint and costotransverse joint. So this is normal here. That is normal. This is fractured. The spinal cord is right back there. That's quite serious potentially. But the other problem we have a compression fracture. All of this is broken bone components on this patient. And the problem is they'll never regain that height. When you get a compression fracture, the vertebral bodies compress. And the Dowager's hump, as they call it, or the increased kyphosis in both men and women with osteoporosis, this kind of effect here, is very hard to reverse surgically. We can do kyphoplasty, vertebroplasty, but very expensive and not always successful. But if we get past the image here and we look at some osteoporosis risk factors, females that are 50 years of age or older, females that are in the state of early or current menopause, excessive weight loss, smoking and alcohol use, family history, chronic steroid use, poor calcium intake, limited sunlight exposure. These are just some of the risk factors. There's many more. So there's two ways to deal with osteoporosis. We can treat it non-medically if that seems reasonable to start, and then we can treat it medically. So let's look at the non-medical methods of treatment. First of all, get tested to see if you have osteopenia or osteoporosis. So osteopenia, I haven't defined, that's prior to the negative 2.5 standard deviations from the standard normal, which is a 30-year-old female, Caucasian woman. You can have osteopenia, and so that's a precursor, not always, but it's kind of a precursor to developing osteoporosis down the road if we don't investigate and see if there's anything we can do to increase bone density. So the first thing is to get tested. The ultrasound that we used for the study I'm talking about here, we did all the free studies for 209 individuals. X number were, and I'll talk about later, were Native Americans, Nez Perce tribal members, and the rest were Caucasian or not Nez Perce tribal members. Part of the challenge in my data when I was defending the dissertation was that I was asked, how do you determine who is non-Native or non-Nez Perce tribal? I said, well, if they're not a member of the Nez Perce tribe, but they're Native. And I said, okay. And they use quantum and blood quantum and quartiles and things like that. But so I did have to have some folks that were in the study. I couldn't use their data. We still went ahead and gave them the free ultrasound QUS scan, a free DEXA, and they took that to their physician. So that was one incentive for folks to participate. So if we look at non-medical treatment here, once we get tested, behavior change, proper diet, weight bearing exercise, and maybe if an older person or someone in their homes, program and fall prevention. And then if we do need to use medication, we would go that way. The reason why I got into public health and health education was because most of my background's in clinical radiology. And I was always stunned at all the patients I saw that had preventable health problems. And I thought there must be a better way to deliver healthcare. And so I thought, well, what do they do in public health and health ed? Well, I thought they do a lot of obviously health education, health promotion, things of that sort. But we have to get patients and individuals to take charge of their own health and also get people to stop thinking of health as medicine. Medicine's only one component of health. So when we did our study, I didn't do this, but there was a nurse educator who was interested in this that worked at the clinic. She did a separate health education program on the diet and exercise. I did that as part of my study, but she did a separate one where she actually would tell them, here's what you can buy at the store. This is what would be beneficial to you as far as calcium or vitamin D intake. So if we're not able to properly treat the osteoporosis with behavior change or health methods, we might have to use medical methods. And so medical therapy might involve increased calcium, vitamin D intake, bisphosphonates like Fosamax, Actonel, Zamida, Urea, calcitonin, Beniva, etc. And these two are a little bit controversial: estrogen replacement therapy and parathyroid hormone therapy. There are some studies, particularly in Europe, show there's an increased incidence of breast cancer for women that get the estrogen replacement therapy and also parathyroid hormone. Some US studies show that, some don't. So it's sort of a mixed thing, but a lot of physicians are leery of prescribing that for a patient that may later develop breast cancer from this. So we looked at the study setting. It's the Nez Perce Tribal Clinic in Lapwai, Idaho. Lapwai is Nimi-Pu. So the Nez Perce tribe, that was the name the French gave them because they wore nose rings. That's not their name for themselves. So I talked to Dr. Ritzel, my chair at the time, about should I use Nimi-Pu or Nez Perce? He says, well, you should use both and be respectful. He said, but the thing is, they're known federally as the Nez Perce tribe. And so Dr. Fox said, yes, go ahead and use that terminology. But there were 3,499 registered Nez Perce tribal members, and then 39,531 residents in Nez Perce County, Idaho, when the study was done in 2013. Reservation is open to non-Nez Perce tribal members. I could use the health center there, and I have no Native American background. I was employed at the hospital. I took x-rays and did other stuff. But I could not actually get care there as far as being seen by a provider. Now, they were under the Portland, Oregon Indian Health Service, and they wanted more autonomy and sovereignty. So since I did the study, they have changed to where now they're able to serve more Native American folks and do it in the manner that they feel is appropriate, culturally, economically, etc. So the study was done August 19th through 30th, 2013. And I lived at the Nimipu Clinic from 11 a.m. to 1900 and 10 a.m. to 1800 on Saturdays. I was there a while. It was fun though. And it was there at the Nez Perce Tribal Clinic or Nimipu Health Clinic. That is a beautiful facility. It's amazing. They didn't know about X-ray, couldn't what to get. They had stuff from the 1960s still there, and it wasn't even passing the inspection. And Idaho has very loose X-ray inspection laws compared to Montana and other states. So it just finally quit working. So the doctors said, we need to equipment, let's get it. So Portland was like, well, we'll put in the budget, etc. When they sought a little bit of freedom from the Portland IHS office, they were able to make those kinds of decisions more rapidly. They still get support from IHS. The radiologists that read all the images are based in Portland, but it was the best of both worlds in a sense. So we had 209 consenting volunteer Nez Perce tribal members and non-Nez Perce tribal members, male and female, age 18 years of age and older, who are residents of Nez Perce County, Idaho. So this just shows a little bit about the Nez Perce tribe. This gentleman is a friend of mine. He actually works for water conservation there, and he decided to bring his mom, his grandma, his daughters, him and his wife in to get the free scans. And guys were teasing and says, men don't get osteoporosis. He goes, well, they must. And he didn't have it, but some of his family members did or had osteopenia. So anyway, very good guy and good friend of mine, Ben. And this just shows, this is a historical exhibit. The clinic is over here, the nice new clinic, but they still have some historical exhibits there in Lapway to just kind of show how things were, or in my mind, I certainly don't know this for certain, how people like me think it was, because I don't know that that's really accurate. And so the idea is that cultural sensitivity is very important. And they knew that I had not had any experience with Native American individuals prior to doing the study. But I ended up working at the clinic, one of the best jobs I ever had. And then when I left, I had a birthday party that they put on for me, and there's like 300 people there. And here's the funny thing, I knew about 5 of them. I knew the doctors and the nurses. I didn't even know who the other folks were, but it's a lot of fun. And then another guy says, don't think it's all for you. I go, why? He goes, we like to have parties, and you're the excuse to have one today. I go, oh, perfect, thank you. So it was good. So this shows kind of the current area. The Lapway Reservation is right there. And so it is, of course, in Idaho, but traditionally, Nimipu, they were in all parts of the Pacific Northwest. They were in British Columbia, Washington State, Montana, Idaho, Wyoming, parts of Utah, Nevada, maybe California, of course, Oregon. But this is kind of historically the size of the reservation right now. This is very important to members of the Nez Perce tribe. The Bear Paw Battleground, where Chief Joseph fought, and they were chased, and they almost made it to Canada. And I wish they had, but anyway. So what happened was when they couldn't go any further, Chief Joseph said, I will fight no more. And he made the right decision because basically he wanted to preserve his tribe and the members of his tribe. So he's a good leader, did the right thing. This is more historically accurate. So you can see that the Nez Perce tribe area goes far up into Canada and British Columbia, very far down and past Idaho. So that's the reservation, and Lewiston is where I used to work at LC. But anyway, Lewiston's the major city right there. So a lot of our clients would come to Lewiston 12 miles away for healthcare, shopping, things like that. One problem with diet and exercise, there was not a health clinic at the medical clinic for people to work out. And so there's a lot of poverty on the reservation. And so folks didn't have a place to go. They maybe didn't have transportation. So we ended up building a health clinic where people could go and exercise after this osteoporosis study was done. And it wasn't just because of that. They'd already been planning that for a while. But the idea was it would serve not just Lewiston, but it would serve folks in Nez Perce County, and a lot of the Native American folks started going to that. So the purpose of the study was to implement the expanded health belief model and use surveys to determine if there's a statistically significant difference in osteoporosis attitudes, knowledge, beliefs, and self-efficacy, and a statistically significant difference in participation in osteoporosis educational seminar among Nez Perce tribal members and non-Nez Perce tribal members, male and female, age 21 and older in Nez Perce County, Idaho. Notice I had 18 earlier. I started with 18 and my advisor said, we want you to make that 21. So I need to get that out of the presentation. But now, as a clinician, I thought this is great. So I told Dr. Ritz and Dr. DT, I said, once we do the survey research, let's scan them, because I already do that anyway, regular patients. Let's scan them with the QUS and the DEXA. They says, no. I go, why not? And they're like, it's too much for you. You're good right now. You can't do all this stuff. And so I'm kind of disappointed. So I had the capacity to actually scan them and did other patients. But I find it bothersome that I don't actually know the people that were in my study as far as doing the survey research who actually had osteoporosis, osteopenia. So that was a little unfortunate. I wished I was able to do that. So the need for this study, we looked at a lot of data. Obviously, Dr. Fox wanted it done, but there's a large amount of data that concerns osteoporosis, female, male, Caucasians, of course. But we wanted to find out what is the osteoporosis incidence, prevalence, and severity amongst other groups that may be underdiagnosed via in gender and ethnic groups. So the research here is dated there, but findings show that osteoporosis among American Indian and Alaska Natives needs further investigation. And this was a study that was pretty good that was done in Alaska. So the Indian Health Service out of Portland approved the study. Dr. Fox had to approve the study. They had a committee, of course, there who would approve any kind of medical research. So we went through that committee. I had to go through the SIU approval process. That was challenging. One thing that helped me get approval was not doing the QUS DEXA scans, because the nice person that was the chair of the Southern Illinois University IRB committee was very anti-X-ray. And I tried to explain to her that DEXA is so low, you get more exposure from cosmic radiations in a building. We don't even give a person that's scanning 8 hours a day a monitor because the amount of radiation is so low, plus ultrasound is non-ionizing. And she's like, I don't like the idea of radiation of any kind. I'm like, okay. So getting it past her, she did her due diligence. She was very good, great lady. But it was a challenge. It was. We also then, of course, after that was done, the Nez Perce Tribal Executive Committee, Legal Counsel had to look at it. And then, of course, the Health and Safety Committee, or IRB, approved it. And I have all that data. Now, this is kind of important here, the study. So other people have been doing this kind of osteoporosis research for a while. So through my research, I found out that these professors, nursing professors at Grand Valley State University in 1991 had been using the expanded health belief model to determine participants' osteoporosis attitudes, knowledge, beliefs, and self-efficacy. And so I talked to them and they let me use their questionnaires, which was great. They then said, hey, when you're done, send us the data. And I did. I don't know. I guess I could look. I don't know if anything has happened. A lot of these nice folks are retired now. But they were excited that I was using their model, their questionnaires to do this kind of study on Native American individuals. So here's the old null hypothesis versus the research hypothesis. So naturally, the null hypothesis is that Native American osteoporosis, knowledge, data about exercise, how to avoid osteoporosis, all the questions we talked about would be equivalent to the knowledge that the non-Native American folks had. And then the research hypothesis, of course, is that the Native American knowledge and information garnered from analysis of the surveys would not be equal to that of the non-Native American population. And of course, the research hypothesis was proven correct. So let's look at the 7 research questions. What do Nez Perce tribal members and non-Nez Perce tribal members know about osteoporosis? Number 2, is there a statistically significant difference in osteoporosis knowledge, attitudes, beliefs, and self-efficacy among Nez Perce tribal members and non-Nez Perce tribal members, male, female, back to 18, age 21 and over, residing in Nez Perce County, Idaho, as evidenced by completion of the EHBM-based osteoporosis survey instrument. Survey instrument consisted of 3 components. We'll start to look at those here in a moment. So research question 3, does ethnicity have an effect on Nez Perce tribal, non-Nez Perce tribal members' knowledge, attitudes, beliefs, and self-efficacy regarding osteoporosis? Number 4, does gender have an effect on Nez Perce tribal, non-Nez Perce tribal members' knowledge, attitudes, beliefs, and self-efficacy regarding osteoporosis? Number 5, does age have an effect on Nez Perce tribal and non-Nez Perce tribal members' knowledge, attitudes, beliefs, and self-efficacy regarding osteoporosis? Number 6, do Nez Perce tribal members and non-Nez Perce tribal members understand the relationship between nutrition and osteoporosis? Number 7, do Nez Perce tribal members and non-Nez Perce tribal members understand the relationship between exercise and osteoporosis? So those are the main research questions. I had more, but my committee said, let's tone this down a little bit. So we looked at the methodology. It's a descriptive study. We analyzed the responses to the 3 instruments, the osteoporosis knowledge test survey, the osteoporosis health belief scale survey, and the osteoporosis self-efficacy scale survey. These expanded health belief model surveys were analyzed with SPSS and SAS. So survey was administered to 215 individuals with 209 surveys completed and collected. The reason why we had some folks we couldn't use, they weren't able to identify whether they're Nez Perce tribal members or not. They said, I'm Native American, but I don't really know. But I'm like, well, that's okay. You can self-declare. And then one gentleman that was with his wife, she says, I don't even know if I'm Native American. I says, well, there's ways we can determine that. She said, is it okay if I just get the scans? I go, of course. So we did that, but we weren't able to use folks that couldn't self-identify into one of the research groups. We weren't able to use that data in the study. So we look at the components of the health belief model. This was my favorite model in health education. I just love it. I still do. And I feel it has great utility. I know there's some other good ones out there. They tried to convert me, but I hung on with the health belief model. But anyway, I feel it does have some utility. Perceived susceptibility, how likely do you think you are to have osteoporosis? Perceived severity, how serious a problem do you believe osteoporosis is? Perceived benefits, how well does the recommended behavior reduce the risk associated with osteoporosis? Finally, cues to action, what factors cause you to change or want to change your behavior in order to not get osteoporosis? So Dr. Bandura added the self-efficacy component to the health belief model. Around 1977, he'd done research prior to that, of course, but one of the areas talking about that I got in the that I looked at in the research was in 1977, and he says that one's conviction that one can successfully execute behavior required to produce outcomes is known as self-efficacy, and he felt that was very critical to add to the EHBM or just the HBM, because he felt, okay, so people know that it's severe, or they feel it's severe, they might be predisposed to get this disease. What are they going to do about it? How do we measure that? And that's an important component of how do patients take charge of their health, or what situation will allow them to do that. So as the health concerns nation have shifted lifestyle related conditions, self-efficacy has taken on greater importance, both independent construct as a part of the HBM. And it's not just used there. I've had friends that did research on cardiovascular disease and fitness in relationship to that, or obesity, things like that, using self-efficacy with the HBM. So here's the knowledge test, just used to test participants' knowledge about osteoporosis, osteoporosis prevention, osteoporosis treatment. So this was one of the research tools developed by Horan and Gedler and the other nursing professors at Grand Valley State University. It had been vetted and statistically evaluated, and so was acceptable for our study. Then we also used the second research survey or tool, was the osteoporosis health belief scale, used to test participants' beliefs about susceptibility, severity, barriers, benefits, cues to action regarding osteoporosis prevention and treatment. And then we also had the osteoporosis health belief calcium intake scale, and then the exercise scale. And it was interesting. We'll see later that there's some differences in knowledge related to calcium intake and exercise that were relevant for the study. So it might be hard to read that. I'm not going to go through all of this, but these are reliability coefficients for the calcium subscales, basically. So we got Cronbach alpha there for all the different components of the expanded health belief model. And then, of course, we've got our values right there. Reliability coefficients were calculated for the exercise subscale. So we did, of course, calcium and exercise. There are some differences, and I can go over those later. So getting back to validity of the model was evaluated by factor analysis and discriminant function analysis. So sample size, confidence level, confidence interval. This is important, of course, for research. Here, what I need to do is I need to calculate what the sample size would need to be for the 95% confidence level. So our confidence interval of 10 is 94 out of a population of 3,499 Nez Perce tribal members residing in Nez Perce County. So basically the sample size for the non-Nez Perce tribal members, the 95 confidence level, confidence interval of 10 was 96 out of the population of 39,531. So we ended up, as I said before, we had 215 individuals fill out the surveys, but really we only used data from 209 individuals. And of those, 128 were Nez Perce tribal members and 81 were non-Nez Perce tribal members. Here's the tricky part. Some of the non-Nez Perce tribal members are Native Americans. So my professors, especially the epidemiology gentleman, who I'm friends with now, but oh man, it was a challenge. He said, why didn't you just make another subgroup and separate those out and just not call them Nez Perce tribal, let's say they're Native Americans? And I said, yes, that would have been brilliant. That would be great. And my committee chair says, in the future, that's what you'll do. So anyway, but it was, I think, a faux pas in the study, and I wished I had done that. So here's multivariate analysis regarding the exercise scale and correct knowledge. So we've got some nice p-values here and some that are statistically significant, of course. And so as we know, 0.05 is significant. We've got the nutrition multivariate analysis and some other p-values right there. It's for the odds ratios there. Let's see. And then main effects of the t-tests for barriers to calcium intake. So we looked at females, Native Americans, non-Native American, males, Native American versus minus non-Native American, Native American females, males, and then non-Native and then females and males. So to interpret this, and this is one of the more important parts of the study in my opinion anyway. So we look at the barriers to calcium intake, the dependent variables, and then the independent variables. So the independent variables is natives versus non-Native American females, Native versus non-Native American males, Native American females versus Native American males, and then non-Native American females versus non-Native American males. And rather than go through all this, we did ANOVAs and two-way ANOVAs. To get to the very bottom here, female Native Americans perceive the greatest barriers to calcium intake. Now, on the reservation, there is no grocery store. There's a casino that's open 24/7. But the food is not necessarily healthy. You can make healthy choices, of course. Folks have to either have their own transportation or take Nez Perce tribal transportation to go to Lewiston or Clarkston to buy groceries. There is a 24-hour gas station, and they sell candy bars and ho-hos and things like that, and beer, of course. And so that's what a lot of people who are place-bound have to eat. And so a lot of the younger women that had children, or if women of any gender age, they felt they didn't have access to calcium or even good food. And our study kind of demonstrated that that was the case. So to summarize, it's a descriptive survey study conducted to determine if there's a statistically significant difference in osteoporosis attitudes, knowledge, beliefs, and self-efficacy. Nez Perce tribal members, male and female, aged 18 and older as compared to non-Nez Perce tribal members, male and female, 18 years of age or older in Nez Perce County, Idaho. So to conclude, there was a statistically significant difference here in osteoporosis knowledge, attitudes, beliefs, self-efficacy among Nez Perce tribal members and non-Nez Perce tribal members, a male and female, age 18 and over, reside in Nez Perce County, Idaho, as evidenced by completion of the expanded health belief model-based osteoporosis survey instrument. So to conclude, the research hypothesis is accepted. No hypothesis is rejected. Okay. And for the 7 research questions, that's about 50 pages of stuff to read through. But rather than do that, I'm just going to go over the 7 and give you the answers here. And then we can talk more about it if there's time. So research question 1, what do Nez Perce tribal members, non-Nez Perce tribal members know about osteoporosis? Both groups have some valuable limited knowledge about osteoporosis, but it wasn't complete. my dissertation fully explains that, and I can provide that to anyone that's interested. So whether you're attending online or in person, just so you can read over that. A research question two, let's see. Let's find that. Here we go. Is there statistically significant difference in osteoporosis knowledge, attitudes, beliefs, self-efficacy among Nez Perce tribal members, non-Nez Perce tribal members, male and female, age 18 and older, residing in Nez Perce County, Idaho, as evidenced by completion of the expanded health belief model-based osteoporosis survey instrument? And there is statistically significant differences between the groups. Research question three, does ethnicity have an effect on Nez Perce tribal and non-Nez Perce tribal members' knowledge, attitudes, beliefs, and self-efficacy regarding osteoporosis? The answer is yes. Females felt that they had an increased propensity to get osteoporosis. They felt that their diet didn't have enough calcium. They had no way or places to go for exercise. And so some males also said that as a rule, the female group, both Native American, Nez Perce tribal, and non-Nez Perce tribal, felt that way. Research question four, does gender have an effect on Nez Perce tribal, non-Nez Perce tribal members' knowledge, attitudes, beliefs, and self-efficacy regarding osteoporosis? The answer is yes. Back to what we saw earlier about the t-test analysis, Nez Perce tribal females felt that they had the least ability to get calcium as needed. Research question five, does age have an effect on Nez Perce tribal, non-Nez Perce tribal members' knowledge, attitudes, beliefs, and self-efficacy regarding osteoporosis? The answer is yes. Research question six, do Nez Perce tribal members and non-Nez Perce tribal members understand the relationship between nutrition and osteoporosis? To some extent. So, and we could elaborate more on that, and I can certainly provide you the data if you want to look that over yourself. And our final research question, number seven, do Nez Perce tribal members and non-Nez Perce tribal members understand the relationship between exercise and osteoporosis? Yes. In fact, there was more of a relationship, positive relationship, between males, both Nez Perce tribal members and non-Nez Perce tribal members, regarding exercise as a preventative measure for osteoporosis. Females of both groups were more focused on the calcium intake. So that's the end of my formal presentation, but I'm happy to answer any questions you may have or discuss possible future research that can be done in this area. Will there be questions from folks attending online, or do we? Oh,
I'll ask my question.
Thanks.
For your presentation.
Oh, thank you.
And I understand your work was a survey
Yeah.
evaluating quantitatively. But in this field, are there people who have looked at qualitative approaches
Yes.
to understanding people's perceptions of osteoporosis?
Absolutely. In fact, there's a dearth of that data. There's a lot more data in that regard. And what happened was, when I was doing my dissertation, we had some major professors who'd been at SIU for years that were qualitative experts, and they retired. And the folks that I was working with, as far as my two dissertation chairs, I had a co-chair because Dr. Ritzel ended up retiring, but he came back out of retirement when I defended, which that's cool. They were more quantitative guys. And they said, we're not against mixed methods. We're not against you doing some qualitative work, but there hasn't been a lot of quantitative work. This would be an opportunity to do that. So my committee chairs sort of directed me to do more quantitative. Yeah. So.
Is osteoporosis, is it reversible?
Once you get past a certain point, you'll still be technically defined as being osteoporotic, but with certain medications, we can stop bone loss. So you might still be in the threshold of osteoporosis at the negative 2.5 standard deviations, both a 30-year-old female, Caucasian normal. But if we can stop bone loss, that's a huge victory, because you can actually be osteoporotic by the World Health Organization standards and not have fractures and not even know you have it. The problem with osteoporosis for any gender group is it's insidious and it starts young. They think in females, on average in the United States, early osteopenia or bone loss begins at the age of 14. Young girls don't know that. They're in junior high. Guys don't even think about it. But men are living longer now, so they're starting to develop osteoporosis. So we have to start thinking as a preventable lifelong disease that occurs very slowly and progressively. But so some patients, we can reverse the technical definition of them being in osteoporosis. Others, we can't. We just stop bone loss, which that's better than nothing. Because in like 30 years ago, we weren't able to do that.
And one more question.
Yes, okay.
Research question 5
Uh-huh.
about the age. Was there a difference between like younger folks having a better understanding versus older folks?
No, older.
Older were more tuned in?
Yes, because they realize they think of it as an old person's disease.
Okay.
So just like diabetes was big, and I thought of doing some research on that because that's a huge chronic disease situation in the United States and the world, but also Native American tribes. And also when I lived in Memphis, so with African American folks, they would always be worried about the sweet blood is what they would call it, and the high blood sugar. And so older Nez Perce tribal members and non-Nez Perce tribal members, male or female, both had a sense that as you get older, your bones get weaker, and it's something I worry about. And we had some of the younger ones. We had, I didn't say this, the youngest was 18 and the oldest participant, she was 92. And she was spry as all get out. And she probably has better bone density than I do. But she had a little kyphosis. She was a descendant of Chief Joseph, and her husband had just passed away, a heart attack. He's in his 90s. And she just wanted to, she'd never been tested for osteoporosis. And she's like, can you just scan me? I don't care if it hurts me or not. I go, well, we're not going to do that. But she was right at the threshold. But one thing I thought about, she's 92. She lived there before the gas station, where our gas station was there. She went to a boarding school there. So her diet in her early years was better than what it is today. Because by that time, they didn't make traditional foods like various roots and things that are available there in Lapway. But she had some of that. And also work ethic, ranching, farming, doing stuff, physicality. So Lori Turner, a friend of mine who helped me with this too, she is a professor at the University of Alabama, Birmingham, but I think she may have gone elsewhere now. She said gardening, just gardening is good weight bearing exercise, and that gardening a couple hours a week can actually reduce bone loss. And I know gardening is hard work, but I didn't think of that as weight bearing. So, but yes, go ahead.
Oh, sorry, there's someone online actually.
Oh.
Let's let them.
Rachel, do you want to unmute?
Sure, thank you. Hi, I'm Rachel Peterson. I'm an assistant professor in the public and community health sciences. Thank you so much for your presentation. My background is in health promotion, and so I'm very much interested in this kind of work. One of the things that struck me is that you recognized early on kind of, and you're continuing to discuss some of the limitations in terms of structural limitations to, access to services, to supports for health behaviors and health promotion. It seemed like, and please correct me if I'm wrong, that in the surveys that the participants were fairly aware of these limitations, even if they had more limited knowledge of osteoporosis. Is that correct?
Yes. Because of living on the reservation, the limitations in food sources, exercise facilities, transportation, and they sort of put 2 and 2 together and realized that could affect me as far as my bone density. And the folks that lived in Lewiston that were non-Nez Perce tribal members, non-native folks that did not live on the reservation, they had some knowledge of that too. To get more specific, what I could do is I could send you the dissertation if you want me to, email it to you, and then you can take a closer look at the exact data itself for your question.
Yeah, it surprises me that we're still using 2.5 standard deviations departure from the need of white women as the standard.
Yes.
Are these data not available through NHANES? I would think that there'd be plenty of normative data, well, perhaps not for Native American
Right.
populations, but for others.
There's more data, and this study is 10 years old, but I've seen more NHANES data and other data sets for Caucasian males, and I've seen more data for African Americans of male and female. I haven't seen a lot of new data for Asian American folks, male or female, or Native American folks. or technically Alaska Natives or, American Natives, so. But yeah, I think that's certainly something we need to do, and that's when I talked to Merck, they were interested in getting the data because it would be a way for them to build a database possibly that does not rely totally on standard normals that we've used for 30 years. Now, in Europe, they're further ahead than us. They're doing more things as far as getting away from that limitation. Then there's not a large Native American population there, but there's lots of other ethnicities, genders, etc. So they're kind of doing more along that line. You might have tried out Klaus Klein at the University of Cologne. He was friends with Dr. Ritzel, and he helped me out with some of my dissertation statistics, what I should be doing. So, but I still got his email. So I haven't talked to Klaus in 30 years, but it's been a long time. I haven't talked to him in probably since 2002, so 21 years roughly. But he was interested in doing osteoporosis on folks in Germany. And then also, he was very big on fall prevention. He thought that fall prevention, a lot more work needs to be done with that.
Okay, any more questions online? Okay, if not, then thank you very much.
Oh, thank you. I appreciate it. Thank you.
Ah,
So we look at the TV when they're asking questions. I can do that.